So today, one of our last Pocket Talks, and probably the last one that we're going to be doing at least session-wise for a couple years, but we're recording and posting all these. So today's talk is a difficult one, so navigating the driving discussion. Um, in this talk, we'll be at least reviewing some of the statistics we have, at least in the state of Kansas, and some of that applies to just older driving in general. But then we're going to tie it into sort of the neurobiology that happens with different dementia syndromes, different cognitive disorders, and how it might relate to driving concerns. And then appealing to personal responsibility, liability, some of the things we have to do if someone's at least not making the right decision. Some people are just, they have lack of insight into the symptoms, right? If there needs to be sort of a gold standard objective tiebreaker here, right? What does a proper evaluation look like? And then we'll also talk about kind of last resort options. So when we see patients in the clinic, we're oftentimes meeting them for the first time, diagnosing them with a progressive cognitive disorder, and then we may or may not have time to talk about one of the most difficult topics in medicine. And so this is sort of the elephant in the room, and we know that there's a substantial number of individuals as they reach age 80 or older that have cognitive impairment, whether it's been recognized or not, but not everyone does, right? And not even everyone with like an early Alzheimer's process is unsafe to drive, especially in those mild stages. So, I think there's not a sort of black and white answer with any of this. And when states have tried to do that, so like California, when they suggested that if you get diagnosed with Alzheimer's, you automatically lose your license, that just results in individuals not going to the doctor to get a diagnosis. So we have a difficult tightrope to walk with all of this, right? And it's a major quality of life issue. So, if we tell individuals these are the things you need to be doing to best help slow things down and to best help support brain function and cognitive reserve in the midst of pathology, how do you do that, right? When we also say don't drive there, right? And so, this is a societal issue, right? Not just at a patient level. This is a public policy problem that we have. From a statistics standpoint, so if you look at, so we all know that younger drivers are at a higher risk of motor vehicle accidents, and even this is just listed as crash deaths here. So this is split between males and females. There's a frontal lobe connection problem here, right? Especially, the frontal lobe doesn't fully connect until you're around age 25, 29. That's when we start to see further declines in the crash deaths. But after about age 70, we see it spike back up. And if there is problems with the brain networks as we get older, right, that's one of the issues. There's processing speed, right? There's motor function, there's vision, right? There's lots of reasons why we see this increase as age occurs. If we view it another way, though, because our younger drivers are also driving a lot more than our older drivers, at least from a 100 million miles traveled standpoint is how this is listed. So certainly high still in the young group, but it's even higher, at least for how much these individuals are driving, how many fatal accidents we're having. If we look at just the state of Kansas, so 1 in 5 fatal crashes in the state of Kansas involves a driver over age 65. This is one of the top, so we're like in the top 5 across the states. So it's a major issue just when we think about aging in general. Your eyes don't see better as we get older, right? Your motor function and processing speed does not improve as we get older. So there's that aspect to think about. And we're just seeing a lot more people reach age 70, right? So if we said it's about 30 million around 2011, 2012, that number is going to double by 2030. And so it's estimated, if we kind of use these crash statistics and plot them out, right, that almost 25% of total driver fatalities will be in this age group, and we'll see a significant increase in those overall crashes. And so if I had $1 for every time that someone said, I've never had an accident, doc. I'd be a rich person. But that decision to stop driving should not be after something severe has happened, right? That's what we're trying to prevent, and part of what the mission with the AARP driver safety is, and part of what the roundtable discussions in the state of Kansas with the Department of Transportation and others are trying to pursue. Some have brought up ideas like driving assist options, right? So, a lot of the newer cars have these driving assist options. Here's just kind of some examples of what can occur. So, if we know that contrast difficulties are occurring with aging, can there be advanced lighting systems, night vision systems employed? Better pedestrian detection. We have all these different cameras that can be put on the cars, right? For warning systems, lane departure warnings, blind spot detections, automatic braking. There's lots of things that can be applied to cars. I had one patient, they said, well, yeah, we bought a new car and it kept beeping at me while I was driving, which was the lane departure warning thing, and they just turned it off. So obviously, one would have to use these and know how to use them. It's really hard, especially when someone's having, short-term memory changes, for them to learn something new, right? You can't instill a new memory in someone that has impairment of new memories. So these are things that would have to be sort of fine-tuned well before someone has symptoms in most scenarios. But these are things that, could help, especially just when we think about the aging population in general. If there's difficulties with, turning the neck and just restrictions that way, we've got all sorts of blind spot detection systems, right, that could help out. When we see patients in clinics, there's lots of different scenarios as far as the spectrum of concern. On one end of the spectrum, this individual may barely ever drive. They only drive to one place that's, less than a mile away. They may live in a small town, country roads. There may be no concern. Now, some of that may be just we're unaware of any concerns, right? But like, no one rides with this individual. So that's kind of one end of the spectrum. On the other end, kids are quite concerned. Grandkids are not able to ride with this individual. We're concerned about their driving, but they can't be the bad guy, and that's sort of the perfect role for the clinician, because we need to step up and make that sort of objective decision for them. I usually, if I'm kind of, and it's never a black or white issue unless we're kind of in more severe stages. A lot of times it's I'm concerned, but I don't have enough evidence to where I'd say, you have to stop. And so I usually give patients and family members sort of some red flag warning signs. So, typically if they're getting lost, that's a potential concern, especially if it's in familiar areas and it's a more of a consistent problem. We do not want individuals ending up 200 miles away from their destination. That can cause severe issues. And then if they're failing to obey traffic signs or signals, cutting off other drivers, reacting slowly to the environment. And how would you know these things? Well, you have to ride with the individual, right? There's no way of knowing. Most patients are not going to be aware they're straddling lanes or they're making wide turns unless someone else identifies and reports it. Using poor judgment, having trouble judging distances. So maybe they're stopping, 2 car lengths away from where they should. Maybe they're, sort of parking in sort of where it's not even fitting the line. They've got dings on the car from parking in the garage. So that can be an issue. Having a lot of near misses, getting honked at. I think one of the gold standard questions to ask is, are grandchildren allowed to ride with this individual? And if not, why not, right? So that's a pretty big red flag for me. And then have there been kind of repeated accidents, even small dings that are kind of unusual for this individual, and then any increase in the amount of tickets they've been receiving. So when we kind of apply this to, neurocognitive disorders, I sort of have my rank of concern. So at least my rank, so the patients with posterior cortical atrophy or shrinkage in the back part of the brain, and we'll look at a couple of cases. This is another way for me to get some more cases to you guys. Lewy body disease is right up there, frontotemporal dementia as well, amnestic, sort of the typical Alzheimer's disease presentation, and then Parkinson's disease, an atypical Alzheimer's presentation. And then if we think of like primary progressive aphasias, which we had a whole talk on as well. In order to like convince a patient that it's unsafe to drive, frontotemporal dementia can be the hardest one. Or when Alzheimer's disease affects that right hemisphere more than the left, it can be quite difficult. And then sometimes the dysexecutive folks. So when we think of the brain, there's different areas of the brain, with the visual association area being the back part, right? So we know that that would probably be impacted with driving, but in the medial temporal lobes, that's kind of where your navigational like place cells are in the brain. And in the front part, we've got our judgment and decision making, right? Processing speed aspects. So there, different parts of the brain are working in tandem to try to help us function in a complicated task like driving. With our PCA patients, or posterior cortical atrophy, as I've shown you in a different previous talk, the back part of the brain is the area where we see a lot of troubles using the glucose on this PET scan. So that's where the damage is. This is where the tau is depositing. We can see that in a tau PET scan here, where the back part of the brain is primarily where the problem is. You can do a brief little bedside test to test that. So we throw up like on a big page on the screen, we'll throw up a whole bunch of E's, right? But they're supposed to be able to recognize that there's also an A, that all these little E's are making up a larger letter A. Same with the middle one here, being able to see the E, but they can see all the little letters. They can't see the forest here, right? They can't see the whole picture. And then another way to test that is with overlapping objects. So individuals will have difficulty sort of recognizing that there's a teapot within this madness of overlapping objects, right? They'll kind of pinpoint that there's a number 8 here, not recognize that it's a lid. I've had this described as an elephant trunk, or I think I heard a turkey head one time, right? So, they're able to see pieces of the picture, but not the whole picture, which, to give you an unsettling thought of the day, in the state of Kansas, this is how much vision you need to drive. So basically, you just need to be not legally blind. So that's as of 2014. The national guidelines is that we should have 100 degrees of field of vision rather than 20. And even our state requirement used to be 110. And there's no clear reason why this was changed, at least when others have tried to look into it. So something that needs to get modified for sure. On that sort of spectrum of back of the brain problem, right? So the posterior cortical atrophy affects that area, but so does dementia with Lewy bodies. So we tend to see the glucose metabolism problem in the back part of the brain again. So it's, that's the area that's processing what your eyes are seeing, so visual information. But also in Lewy body, we're also dealing with motor symptoms too, in a lot of cases, at least in the majority of cases. And this might be what their cube and clock looks like as examples. And again, we have that back part involved. So this can disrupt a lot of the different functions we've discussed here. When we look at so the majority of patients with progressive cognitive issues, 2/3 of the time are this typical Alzheimer's disease where it's short-term memory predominant. And I've shown you this picture before of kind of where the damage in Alzheimer's disease tends to target first is these memory structures, is what we call the hippocampus. And these individuals can usually drive in familiar areas pretty well. So maybe that local 5-mile radius type of thing. If they use GPS in the past, they can get away with using it even to unfamiliar areas. They can still do quite well with that. However, if they've never used it, it's going to be really hard to learn something new like that. And the reason being is part of the anatomy of this hippocampus, this short-term memory structure, is also where those place cells and your sort of mental maps are registered. So that's why, the maps are stronger for those very familiar areas, but they're going to struggle more with the novel and complex environments. And this changes over time, right? So if you look at these memory structures down here, over time, we see further worsening. And so it usually goes along with, as we see more short-term memory impairment, the navigational abilities follow closely behind. When we look at, so for the young onset folks that tend to have more of so younger than age 65 presentations of Alzheimer's, About 80% of those folks have more of this dysexecutive Alzheimer's disease, where it's the frontoparietal lobes that are much more heavily hit, whereas oftentimes the parietal lobe is the epicenter. And sometimes we'll even call this a hippocampal sparing disease. But they're also highly reliant on a GPS, and it's not necessarily because the place cells are failing, the navigational areas of the brain. It's because they cannot do multitasking. So, if they're having to focus on directions of where they're going and driving, that can be an issue. So if something's kind of telling them where to go, they can focus on the driving. Reducing that mental processing, reducing that multitasking can help. I mean, it's to the point where oftentimes they can't have conversations in the car. They can't be listening to something in the car. That's just too much distraction when the working memory is disrupted. When we look at primary progressive aphasia, this is an example of an Alzheimer's disease cause. We call it logopenic primary progressive aphasia. It affects the language network, so you can see it along the left lateral part of the brain, much more than the right here. And this is a language variant presentation of Alzheimer's disease. It also usually spares the hippocampus early on. Now, so most folks are not having issues driving because of this condition. It's just kind of depending on what stage we're at. If they're having troubles getting the words out they want to say, what if there was an emergency? Troubles communicating could be an issue. But again, that kind of depends on the severity of their aphasia for most of those issues. I mentioned the frontotemporal dementia subtypes. So, the front part of the brain, what does that do? Well, it's partly our behavior and personality, especially on the right side of the brain, but that's also where our insight, social learning, that kind of social context is arising from. And so if those areas are compromised, we see poor judgment, concrete thinking, so sort of that lack of cognitive flexibility, impulsiveness. Think of road rage, right? These types of things can be a major issue for these patients with driving, and ultimately can impair their decision-making and processing speed as well. And then the other primary progressive phases, it's usually that left side of the brain again, and these are just the other different types that we've looked at in prior talks. So when we are seeing patients and we're quite concerned, one of the reasonable tactics to use is to appeal to that sort of responsibility and liability. So I will usually have a conversation of, I'm concerned about driving. And when we're dealing with something that's going to get worse with time, which is what these neurocognitive disorders are going to do, it's not a matter of if, but when it is time to retire from driving, right? So initiating that conversation even early is important. Yeah, especially for primary care providers who are seeing patients, regularly. For most patients, there's going to become a time to stop driving, especially when we're dealing with something that's progressive. We want to maximize their independence, but obviously as safely as possible. And so, if there's ever that sort of, well, we're unsure, we're not seeing any obvious signs, but the testing might indicate there could be concerns, then that's where sort of an on-the-road driving evaluation is really the gold standard of, is it still safe or not? And then, if someone has been deemed to be a concern for driving, right, they get an accident, there's always that liability component too, that patients and families need to be thinking about. And so sometimes if they're able to at least, hey, I've had a formal assessment and I've been at least cleared to drive, maybe not nighttime, but during daytime in these areas, that could help that liability situation as well. It's helpful for most primary care offices, especially folks that see individuals over age 65, to at least have some materials out in the office, especially for families who these conversations are just as difficult and even more difficult for families than it is for us clinicians. So just having some talking points, having some options for them to even bring it up with you is reasonable. I've personally never done this, but the Alzheimer's Association, I think this is a reasonable, especially if you're diagnosing someone kind of at early stages like mild cognitive impairment, similar to how we have certain different contracts with pain medications, right? A driving contract that, if I'm unaware of the change is that I've signed this document saying, I will stop driving once, deemed unsafe to do so, right? I think that really should be where we're moving with a lot of these things. But there's obviously complications with that, because when someone signs this, you could argue that they're a different individual than when we say it's time to stop. And so it's probably ethically a good way to approach this. So when we refer someone, ideally we're doing it at earlier stages of cognitive impairment, from a proactive standpoint. And the idea though is that this is something that's going to change with time, right? And our goal is to still retain sort of someone's independence, and mobility within the community. Those initial recommendations that come back can vary quite a bit. So in some cases, it's just minimal restrictions, right? Maybe, most patients as they get older, nighttime driving is probably not the best. But maybe local radiuses and things like that, maybe avoiding highways, at least high speed issues. But the only way you would know that is with sort of a really detailed evaluation. But there's also the chance that this is time to retire now, right? And so that is one of the outcomes of these driving evaluations. I personally, in our clinic, we, at least locally, utilize an occupational therapy group. And I think that there's a pretty good database of different driving specialists out there. Again, those are going to be mostly in major cities. They're not going to have the resources in a lot of rural places like we should. So, we utilize this Overland Park, rehab hospital in Kansas City. The Ability KC does a pretty good job as well. But I think that, having a thorough evaluation is really important. And so it's not just a virtual driving test, right? Most of the time when if we send our patients to one of the virtual driving tests, it's almost 100%, well, we recommend an on the road. So we just usually skip the middleman there. But let's say the driving evaluation comes back and it is recommended that this individual retire from driving, but they disagree, right? And so they're going to continue driving. We don't have at least a mandatory license revoking capacity in the state of Kansas, but any individual, the physician, family member, neighbor, right, law enforcement can submit letters of concern that will get evaluated, and then you can even put what are some of the things that were noticed, as far as the driving concerns. For families, a lot of times it comes down to some last resort, especially when, I talked about if the individual doesn't have insight to their symptoms, they're not going to stop driving willingly because they don't recognize there's a problem. So sometimes we just have to resort to these last options. And so controlling key access is one, right? Maybe they have a set of keys, but it's not the one that turns on that car, right? Maybe there is a kill switch where only the individuals that know where that is can turn on the car. Sometimes it's selling the vehicle. Sometimes the vehicle's in the shop for a really long time, right? And so there are ways to sort of navigate this. Sometimes the vehicle is the continual inciting, like once they see it, oh, I want to drive. But once you remove that from the situation, then it stops, or at least becomes less of an issue where there's less reminders of that they're not able to drive that car that they keep seeing. So